Hi everyone, thanks for listening to my presentations. Today I'll be talking about brief anatomy of the liver. The liver is known as the largest organ in the body. And this is brief because I will not be able to go through the entire anatomy of the liver within 10 to 20 minutes, but I will do that in future. But right now, I need to go over this so that we could all have the clearer picture of what the liver is all about before I will begin the series of presentations on certain health conditions related to the liver. For example, hepatitis A, hepatitis B, hepatitis C, hepatitis D, and hepatitis E, liver cirrhosis, liver failure, hepatic encephalopathy, and so on. With that in mind, let's go. The liver anatomy will involve the shape of the liver as being wedge-shaped and of course the largest organ in the body. It is located at right upper quadrant region below the diaphragm. When you trace it from fifth intercostal space to the right costal margin along the main clavicular line, you'll be able to get the liver size. Percussion along that line will give you the clue. At about 50 years, the liver is about 5 centimeters, but at adulthood, it's about 15 centimeters, which means the size increases with age. The body size also affects liver size. Proportionately, it is larger in fetus than in adults. It's about 1.5 kilogram in men and about 1.4 kilogram in women, divided into right and left lobes. The right lobe is larger and is at the right hypochondrium. The left lobe is smaller and flat at the epigastrium and left hypochondrium. The liver has four distinct lobes: the left lobe, the right lobe, the caudate lobe, and quadrate lobe. The right lobe is about 6 times bigger than the left. Falciform ligament is separating the right and left lobes. The caudate lobe. Caudate has 3 parts. 1. The caudate process that connects the caudate lobe to the right lobe. The paracarpal part and a Spigelian lobe or lobular spigel, located at the posterior superior surface of the liver, also on the right lobe. This is the posterior hepatic segment 1 at the opposite end of the 10th and 11th thoracic vertebrae. The blood supply to the caudate is from both the right and left hepatic arteries. So, functionally, the caudate is a part of both. The caudate lobe is under the medial segment of the right lobe, and using canal classification is segment 4B. Anatomical borders are essentially that anteriorly is bordered by anterior margin of the liver, and posteriorly by porta hepatis. On the right, bordered by fossa for the gallbladder, and on the left, by the fossa for the umbilical vein. It's functionally part of the left lobe. And why that? Because it receives blood supply from the left hepatic artery. There are variations in anatomy of the liver. Some will have reduced lobe, which is downward tongue-like projection of the right lobe. It could mimic hepatomegaly on physical examination, but it is benign. There are other variations where some people will have beaver-tailed liver, and that is elongated left lobe. It could be confused with hepatomegaly or liver cirrhosis on examination. Some will have papillary process that may extend posteriorly between inferior vena cava and the aorta and could also be misdiagnosed as hepatomegaly. Therefore, when the diagnosis of hepatomegaly is being considered, we have to take into account all these variations. The liver is divided into 8 segments by blood supply. The segments of the liver will contain portal vein, hepatic artery, hepatic vein, and bile duct. Okay, blood supply. Oxygenated blood will come from the hepatic artery, and that will form about 30% of blood supply to the liver. The remaining 70% of blood supply to the liver will come from the portal vein. And both the oxygenated blood from the hepatic artery and the blood supply from the portal vein will mix within the hepatic sinusoid and then drain into the systemic circulation via the hepatic venous system. The hepatic artery. The hepatic artery is essentially the common hepatic artery from celiac axis, and that will branch into proper hepatic artery and gastroduodenal artery. The gastroduodenal artery will proceed caudally to supply the pylorus, duodenum, and the pancreas, while the proper hepatic will divide into right and left hepatic arteries to supply the right and left hepatic lobes respectively. The right hepatic artery gives the cystic artery to the gallbladder. You could see that there is a close relationship between the gallbladder and the liver. The venous drainage. The portal vein supplies nutrients to the liver. Remember, in the last 3 slides I've just mentioned that about 70% of blood supply to the liver is from the portal vein. Now, the portal vein itself is from both superior mesenteric vein and the splenic vein found behind the pancreas. The portal vein also receives supply from coronary through the left gastric and cystic vein, the right gastric, and pancreatico-duodenal veins. The portal vein has no valves, and it has low pressure, between 3 to 5 millimeters of mercury. Still on venous drainage, the left gastric vein or the coronary in portal hypertension becomes the portosystemic shunt and feeds gastroesophageal variceal complex. This explains why hepatic pathology like liver cirrhosis with portal hypertension could give esophageal varices and hematemesis, and so on. The main portal vein divides into right and left portal veins near the liver hilum. The left portal vein has a longer extrahepatic course and gives off a branch to the caudate lobe. The caudate may arise from the main or right portal vein. So, intrahepatic veins coalesce into 3, that is right, left, and middle hepatic veins, then into the inferior vena cava superior. The left and middle hepatic veins may drain directly into the inferior vena cava, but usually through the common trunk. The right is larger and has short extrahepatic course, unlike the left, and drains directly into the inferior vena cava. The parenchymal veins are not having Gleason capsule The glazing capsule is the fibrous protective encasing. The biliary tree. Intrahepatic biliary tree has multiple ducts and is responsible for the formation and transposition of bile from the liver to the duodenum. Typically follows the portal venous system. The left and right hepatic ducts will join near the hilar plate to form the common hepatic duct. The common hepatic duct crosses caudally, that is inferiorly, and is joined by the cystic ducts to form the common bile duct. Through the ampulla of Vata, the common bile duct would drain into the duodenum. Now, there will be sphincter of Oddi. We'll talk about that in the course of liver pathology and pancreatic pathology. The caudate lobe bile drainage is variable. It could drain through the right and left hepatic ducts in 70 to 80% of people, and in 15% could be only through the left hepatic duct, while in about 5 to 10% could drain through only the right hepatic duct. Innervation. The liver is supplied by the peripheral nervous system. It's further divided into a somatic nervous system and autonomic nervous system. Don't confuse anything here because the central nervous system is made up of brain and spinal cord, and peripheral nervous system is made up of somatic nervous system and autonomic nervous system. Now, as far as the liver is concerned, we're dealing with autonomic nervous system, which means the visceral and involuntary nervous system that will play a key role in physiological processes taking place in the liver. The autonomic nervous system could be further divided into sympathetic, parasympathetic, and enteric nervous system. Depending on the textbook or whatever source of your info, you may find autonomic nervous system has been divided into only sympathetic and parasympathetic. Branches of vagal and splanchnic nerves will innervate the liver through the portal area associated with portal vein and bile duct. Hepatic sensing. Only those in medical field, the nurses, the doctors, medical students will know that the liver has the capability of sensing because it's under autonomic nervous system, peripheral nervous system control. Okay, hepatic sensing is essentially that the liver is an effective organ at sensing changes in blood osmolality. Water intake can be detected in the liver prior to its effect systemically. Isn't that great? It can also detect ions and the changes, for example, the level of sodium and the level of glucose. Still on hepatic sensing, the liver has the capability of lipid sensing and then play a role in the feeding pattern. The liver could also dictate incretins, for example, glucagon-like peptide 1. Visceral secretion of glucagon-like peptide 1 occurs primarily in the intestine during food absorption. The glucagon-like peptide 1 has the capability to stimulate pancreas to start secreting insulin. And of course, we know why. Carbohydrate is being absorbed in the circulatory system, and then we need insulin to be proportionately high as well. And then stop or inhibit further glucagon production. With this brief description of the liver, I am now comfortable to proceed in describing the biliary system the functions of the liver, the pathology of the liver, like all hepatitis A, B, C, D, and E, the liver cirrhosis, the liver failure, hepatic encephalopathy, the hepatoma, now all diseases related to the liver. And with that, I've come to the end of this short presentation. Remember to share, remember to subscribe, and watch out for more publications or more presentations on liver-related diseases. Thank you, and I appreciate it.